Hello friends, a very warm welcome to all of you. In this video session, we are going to tell you about a few image-based questions. These are important images that are frequently asked in the exams. So let's start with it. The very first slide that I would like to show you is that this barium swallow is associated with diffuse esophageal spasm, achalasia cardia, scleroderma, or the Chagas disease. What we see in this picture is that this barium has become accumulated in some pouches in the esophagus. And this is a typical characteristic finding of the diffuse esophageal spasm. Diffuse esophageal spasm. This diffuse esophageal spasm, the characteristic finding of the barium swallow is known as the corkscrew appearance. Corkscrew appearance. And therefore the answer over here is the diffuse esophageal spasm. Though in this picture the characteristic corkscrew appearance is not seen, what we see in this picture is the accumulation of the barium in the pouches. Due to the spasm, the esophagus has become divided into a number of pouches. The second picture over here that I would like to show you, what is this? Gross picture of GB is suggestive of cholestyrosis, adenomyomatosis, xanthogranulomatous cholecystitis, like that. This is a specific feature which is seen whenever there is a deposition of cholesterol crystals in the wall of the gallbladder. This gallbladder that is seen here is known as the strawberry gallbladder. Strawberry gallbladder. And this is a typical finding that is associated with cholestyrosis. So for this picture, we have cholestyrosis as the answer. For the next picture, what do we see here? This picture, what is the diagnosis? Is it Crohn's disease or colonic diverticular or ulcerative colitis or the bowel ischemia? This is once again a barium study over here. In this barium study, we can once again see that the barium has become accumulated over here in a number of pouches all over the colon. This is a typical picture of the colonic diverticula. The colonic diverticulas are seen in those patients who have chronic constipation. When they apply pressure to defecate, the intraluminal pressure of the colon increases and the mucosa and the submucosa herniates out through the defects in the wall of the colon. So that way out, the colonic diverticulas are false diverticulum. They are not true diverticulums. They are actually herniations of mucosa and submucosa through the wall of the colon. The next picture over here, this picture was taken during esophagoscopy. What is the most likely diagnosis? Is it Barrett's esophagus or the squamous cell cancer, esophageal varices, or diffuse esophageal spasm? What we see here in this picture is that there is a swelling that is visible over here in the esophagus. This swelling that we can see is typically seen with the esophageal varices. This is a picture of esophageal varices. Esophageal varices are associated with portal hypertension. The lower part of the esophagus and the upper part of the stomach, that is the fundus, it drains through the portal vein. Whenever or during whatever condition the portal vein is blocked, whenever there is a blockage of the portal vein, this leads to the shunting of the portal blood into the systemic vessels, and ultimately as a backflow, the vessels or the veins become dilated. These are known as varices. With portal hypertension, varices may develop at a number of sites. One of those sites is the lower esophagus and the fundus of the stomach, and this is what we are seeing here in this picture. So, for the next one, what is this? This is a CT scan of a 52-year-old male which presented with epigastric pain. What is the most probable diagnosis? The finding over here in this picture is something seen over here. This is like this. Appears to be like a target, and this is known as the target sign. And as all of us know that the target sign is seen with intussusception. So this is a patient who is having intussusception. What happens in intussusception is that there is invagination of a part of intestine into an immediately adjacent part of the intestine. It most commonly is seen at the ileocecal junction in the adults, where this ileum has invaginated over there into the cecal area. So this is our intussusception. One more picture of intussusception over here. This is the target sign as seen on USG. That means we can see the target sign on a CT scan, and the target sign may be seen on USG too. One more important sign that is associated with intussusception is the claw sign. You can see this claw over here. Claw sign in intussusception is visible on a barium enema. It appears like the claw of a talon. So this is our claw sign of intussusception, and this is the target sign of intussusception, the second one. Now for this picture, what is this? What is the sign? The sign is visible over here and looks like the beak of a carnivorous bird, and this is known as the birds of prey sign. Birds of prey sign is also seen with either the sigmoid volvulus or the cecal volvulus. Sigmoid volvulus or cecal volvulus. A few more pictures over here for the birds of prey sign. Here we can see the birds of prey sign, and the second one also the bird of prey sign. So this is it, the birds of prey sign seen with barium enema of or in a patient of volvulus. A number of other signs too may be seen with volvulus. One of the most important sign of the volvulus on double contrast is the coffee bean sign. Here what happens is, because of the volvulus, the intestine has become dilated away like this, and this gives an appearance of the coffee bean. This is a diagram showing the volvulus. So this is a very important and a very common sign that is asked in exams for the volvulus. Coffee bean sign may be seen with the sigmoid volvulus, sometimes may be seen with the cecal volvulus also. Now, what is the diagnosis for this patient? Before giving you the explanation for this, that what is happening in this picture and what is the diagnosis, let us for a little while consider something else. The malrotation of midgut. Malrotation of midgut. Malrotation of midgut may lead to a number of complications. This may present to us with annular pancreas, it may present to us with duodenal atresia, it may present to us with omphalocele, It may present to us with gastroschisis. It may also present to us with volvulus of the midgut. For this question, we are mainly concerned with two important complications of the malrotation of the midgut, that is omphalocele and gastroschisis. Omphalocele is covered by a membrane. Covered by a membrane. Whereas the gastroschisis, the herniated part of the intestine, are not covered by a membrane. And therefore, this picture that we see over here is basically of gastroschisis. If this would have been covered by a membrane, it would have been omphalocele. The procedure depicted in this picture is done for. What we can see in this picture is that this is the lad's band. Lad's band. And over here what we see is the volvulus of the midgut. And therefore the answer definitely is already clear to you that this is midgut volvulus. During the intestinal malrotation, what happens is that there is a very short mesenteric base that is available for the midgut, and therefore the midgut may undergo the volvulus. To detarge this volvulus, the first thing that we have to do is to cut out the lad's band, and this is known as the lad's procedure. So this is our lad's procedure, and it is done for the midgut volvulus. Now, what is the picture that you can see here? The diagnosis is, here we see a brain tumor that is attached to the meninges. And by far, the most common meningeal brain tumor is meningioma. This meningioma originates from the arachnoid matter. Meningioma originates from arachnoid matter and it adheres to the dura and therefore known as the dura-based tumors. The most common site of meningioma is the falx cerebri. And this is the picture where we see it. One more picture of this meningioma. Here, once again, we see the tumor attached to the falx cerebri. This is once again the meningioma. In these two pictures, as the name already tells you, that the first one is the craniopharyngioma and the second one is the medulloblastoma. What I am coloring here with red is the brainstem for both of these pictures. In one of these pictures, the first one, we see that there is a calcified lesion in front of the brainstem. This lesion is craniopharyngioma. It is by far the most common cause of suprasellar calcified lesion. The second picture over here shows us the medulloblastoma, which is seen here in the posterior fossa. Medulloblastoma is by far the most common brain tumor in children. And the most common site for medulloblastoma is the cerebellum. Then proceeding with the next picture, what is this? What is the diagnosis for this patient with hearing loss and feeling of ear fullness? What we see in this picture is that there is a chymosis over the mastoid process. This ecchymosis over the mastoid process in a polytrauma patient is known as the Battle's sign. Battle's sign. Why this occurs is due to the fracture of the teres temporal bone, that is the teres part of the temporal bone. This is the fracture of the skull base. Fracture of the skull base may manifest to us with either the battle sign. It may also manifest or present to us with the black eyes known as the raccoon eyes or the panda's eyes. One more manifestation of the fracture of the skull base is that there may be fluid discharge from the nose or the ear. Rhinorrhea, otorrhea. This fluid may be clear or this fluid may be bloodstained. All of these are features of the fracture of the skull base, which is usually the fracture of the teres temporal bone. Now, what is the immediate management for this patient? Should we try to reduce it immediately or wrap in sterile plastic bag, cover it with a tight bandage, or cover with moist saline? The proper management for this problem, where this is a stab wound and a part of the intestine has come out, is to cover this part with a moist saline dressing so that it does not become dry, and as soon as possible shift the patient to an OT, and in the OT we'll perform a laparotomy and reduce this part. Never try to reduce it immediately. What is the diagnosis for this picture? Is it lymphangitis, filariasis, decompression sickness, or electrocution? What we see in this picture is that there is some tattooing of the skin. This is very commonly associated with feather burns. Feather burns. And these tattooing, which appear due to static electricity, are known as the Lichtenberg figures. The phenomena of feather burn is most commonly seen with lightning. Now this lightning is nothing but electrocution. So this is during the phenomena of electrocution when this type of figures may appear and the patient may get burned. These figures, once again I am telling you, is known as the Lichtenberg figures. Now, what is the diagnosis in this patient? A supine X-ray of 22-year-old male following a road traffic accident. What is the most likely diagnosis? The most likely diagnosis over here, as per the finding, we find out that there is mediastinal shift. Then this sulcus of the pleura, this has gone deep down into the abdominal cavity. This is what is known as the deep sulcus sign. Though there is some hyperlucency seen in this X-ray, but it is not very clear. But anyways, this deep sulcus sign and the mediastinal shift is giving us a clue that this is an X-ray of pneumothorax. For this picture, a laparotomy was performed in a male adult with 2 large specimens removed. Which one of the following is false about the condition? Mind you, the question asks false. So 3 of them are likely to be true and 1 of them is false. This is a polycystic kidney disease. Polycystic kidney disease. Polycystic kidney disease can be of 2 types, autosomal recessive and autosomal dominant. The commonest variant of polycystic kidney disease is autosomal dominant, and therefore this picture is most likely to be as a result of an autosomal dominant disease first option is true. Along with cysts developing in the kidney, cysts may develop in pancreas, they may develop in the liver, they may develop in brain. That means there is multi-system involvement, and therefore the second option also becomes true for us. The investigation of choice for this condition is USG. USG is almost 100% sensitive in diagnosing the polycystic kidney disease in a high-risk patient. And this is definitely not going to use any contrast or anything, and therefore it is very good, easy to do. So the investigation of choice for polycystic kidney disease is USG. Third option, that means, is true. What about the fourth one? Most of the patients of the polycystic kidney disease present to us with compromise of the renal functions or renal failure. Under these circumstances, contrast cannot be given to the patient, and therefore this makes IVP contraindicated. Therefore, IVP is not an indication of choice for the polycystic kidney disease, and this is false. It is said that the IVP picture of polycystic kidney disease is the spider leg appearance. But usually in most of the cases, this IVP is not possible. The reason being that there is compromise of the renal function. Now, which serological test is most likely to be positive in this patient? Anti-centromere antibody, anti-double-stranded DNA antibody, anti-Rho antibody, or anti-Smith antibody. This picture is showing us Reynolds phenomena. Reynolds phenomena. Reynolds phenomena is classified into two types. Either we may have a primary Reynolds. The etiology for primary Reynolds is not known. Etiology not known. The second type of Reynolds phenomena is the secondary Reynolds. The etiology for secondary Reynolds is known. Secondary Reynolds phenomena, etiology is known. And by far the most common cause of secondary Reynolds is systemic sclerosis. Systemic sclerosis encompasses a number of different types of varied diagnoses like scleroderma, Crest syndrome, and all of these. A number of different types of diagnoses are possible. They all encompassed in the systemic sclerosis. And the most common autoantibody increased in the systemic sclerosis is anti-centromere antibody. And this is the answer for it. That anti-centromere antibody is increased, most likely to be positive in this condition. So this is it for this session. Thank you so much.